Good afternoon, everyone. How are you? Good. Well, thank you so much for being here. I know it's day 2. I know people are in a rush to start their weekend, and it's after lunch. But I'm here to talk about revolutionizing mental health in oncology clinical trials. Excuse my voice, I'm just getting over a little cold, so hopefully you can understand me and it's clear. But this is a really important topic, and I know my audience, before I came up here, I was speaking with a few of you in the audience, and I know everyone here is not in the oncology field, so to speak. I know some are in vaccines. However, what we talk about today can definitely relate to you as well, as long as you're doing research. How many of you are currently involved in oncology clinical trials, by a show of hands? We have one in the building. I think there's some online. Okay, all right. Well, really quick, I just want to introduce myself. So my name is Wendy Garvin Mayo. I am an oncology nurse practitioner, doctorate prepared. I think this information is very important to my discussion today. I spent over 20 years in healthcare, and I spent the majority of my career in oncology, in the clinics taking care of cancer patients, enrolling them in trials. And then I also spent a significant amount of time in pharma, in big pharma, working as a medical science liaison, as a scientist developing protocols, as well as leading a global team in investigator patient engagement, where we look for different ways to recruit and retain patients in clinical trials. And I have to say, throughout my entire oncology career, something has been very consistent. It's that we do not address the mental and emotional impact cancer has on patients. We do a great job of treating the cancer, of doing all the things, but patients are still suffering. So with that, I left pharma and I created my own practice, Collaborative Cancer Care, to address the emotional and mental health of cancer patients and their family members. And I think it has to go outside of the clinical realm, which we're going to talk about today. And that's why I'm here to talk to you about revolutionizing mental health in oncology clinical trials. So our objectives today, I'm going to highlight the importance of mental health in oncology clinical trials. We're going to discuss the gaps, the current gaps in clinical trial frameworks, and we are going to look at strategies for integrating mental health support in clinical trials, and then showcase innovative ways for future directions. How many individuals here are involved in protocol development, whether it's oncology or not? Okay, 2. All right, so the rest of you who are not, this is still relevant because you can still advocate, right? You can still be on the lookout for this. So let's get started with why mental health in oncology matters. We know that mental health in cancer care remains under-prioritized in clinical trials and in the clinical setting. Okay, we can all just even think about a cancer diagnosis, how it shifts the trajectory of someone's life. So mental health, it goes hand in hand with that. And psychological distress, we also know in the research, it impacts treatment adherence, quality of life, and survival outcomes. If patients are not adhering to treatment, that's going to affect some of our endpoints in clinical trials. If we're looking at progression-free survival, patients aren't staying on trials. So mental health impacts the patient's ability to actually be on the trial and be effective on all of the schedule of events that we have for them. So we don't really talk about that, but it definitely impacts that. And without integrating mental health, we really fail to capture the full experience of the patient and treatment effectiveness. And I know we preach a lot about holistic healthcare, but in order to be holistic, we have to look at the mental health of these patients we are taking care of. So there was a survey done, which I think it's very important to bring this up to really highlight what we're talking about here today. But the cancer support community in collaboration with Biogen, did a survey looking at cancer patients and cancer survivors, looking at emotional distress in these individuals and where they're higher, where they're lower. But two things that really popped up for me was that 60% of the participants were never referred for mental health assistance or support, despite even wanting or needing it. And that's depicted here. So patients are suffering, and not being referred to mental health partners to really help with their emotional and mental distress. And then another significant statistics out of this survey was 40% of them who wanted mental health support did not receive it. And as an oncology clinician myself, I know it's not that we don't want to, right, provide these resources to patients, but there are many factors such as timing, such as staff, such as resources. However, if patients are suffering from anxiety, depression, adjustment disorder, to name a few, we have to get them assistance, especially if they want it, if 40% of them, right, really want the services. And I thought this was really a nice depiction of just distress across the continuum, because before patients are diagnosed with cancer or before they're even going to a clinical trial, they have some distress. So at the time of diagnosis, treatment, and even in survivorship, we're doing a great job of keeping patients alive. However, I always question quality of life. If we are suffering, if patients are suffering mentally and emotionally, how good is their quality of life, right? From the first slide. So these are the patients who will be on our clinical trials, right? Whether it's, after the first progression from, first line therapy, second line therapy, or whether they're even in survivorship, right? But these are the patients who are being enrolled in our clinical trials. There was a study done that looked at, the impact anxiety and depression has on a patient's perception of clinical trials. And this is important because as we try to recruit patients, I looked at some data before I came here, and I think it's up to 7%, which is a little higher. I think it was like 5.2% before, but that's still not high. That's still not high, but it's really based off patients' perception. So this study looked at, anxiety and depression, and patients who are anxious and depressed, their perception of clinical trials are listed here in quotes. I would be unable to fulfill the trial requirements due to logistical barriers. I don't trust the medical establishment and fear I would be used as a guinea pig. I'm uncomfortable being randomly assigned. I fear receiving placebo in clinical trials. I don't understand what clinical trials are, right? And that's a big one. I don't understand what they are, because even though we educate them, they are not taking in the education because they can't focus on what you're saying. They can't focus on the benefits that this clinical trial may have for them, right? So it's not that they don't understand. I think we always run to patients don't understand. We have to take care of them mentally in order for them to actually consume the information appropriately, okay? And I fear side effects that may come with treatment on clinical trials. So this is just to bring home that, the mental health of a patient impacts their perception, which then impacts their belief, which then impacts their ability to take the next step, all right? And then there was another study done where they were looking at mental health in clinical trials and really tracking what patients are experiencing. And this was in patients with GU cancer. And it showed that 80% of the individuals actually on the trial had anxiety and depression. And we had 60% who was experiencing insomnia. So this is great, and I love this because it shows that, one, whoever designed the protocol took it upon themselves to say, let's assess the mental health of these patients on the clinical trial. And two, what I don't know is what happened. And I can tell you from personal experience, when I was in R&D in pharma, PROs, patient-reported outcomes, we're all collecting those. Many of us are collecting those now. But what I'm finding is that we're collecting the data, but like this study, you find out that 80% of them are depressed and anxious, but what are you doing about it? That's the next step. What do we do about it after we identify it? So I think that we have to assess, so this is a great first step, but then we have to take it further, and then what are we gonna do about it? This study here showed that anxiety and depression are associated with higher reports of SAEs in clinical trials. So if you are in, part of clinical trials or you're aware of clinical trials, it's important when you see data start coming in that patients are reporting SAEs, what else are they associated with? Why can that patient be complaining of more SAEs, grade 3, grade 4s, as we see? Is it related to mental health? Possibly. If we treated mental health, could those SAEs decrease? Which will impact the data that we collect, yes? And the data that we present in our clinical trials. So there is a correlation there, and this study here really brought that home. So what are the gaps in the current oncology clinical trials? And I think this is important because when we say current, we have to be innovative. We don't have to do it one way all the time. And I challenge all of you who are here in the room and who can hear my voice, who's watching the replay, is how can you be the game changer in how we actually collect data for patients on clinical trials, specifically oncology for sake of this presentation. But we lack standardized mental health assessments. So we need to make sure we are standardizing those mental health assessments for our trials. Right now, we do focus on tumor response, that's prominent, but we need to make sure that we standardize mental health assessments for these patients. Mental health metrics are not routinely collected. So we do have some PROs, but a lot of them are not collecting specifically if patients are dealing with mental emotional distress. So that is something that we need to do, looking at anxiety, depression, and stress, because all of these impact behavior in patients on clinical trials. Then we have exclusion of patients with psychiatric comorbidities. If you look at a lot of the protocols, it is an exclusion criteria if a patient has a mental health history that is not being managed, right? Not being managed, that's very subjective. But those patients should be included because those patients should also benefit from the benefits of a clinical trial. Lack of psychosocial interventions within trials, and I said this a little earlier, that if we assess, then what do we do about it? So we should have those already set up preventatively and be proactive about collecting the data, but also when we identify issues, what are we going to do about it? So what are some solutions for transforming clinical trial frameworks? So there's a few, and these are just a few. There's many more that we can do. But we want to incorporate validated mental health tools into trial protocols. We want to do this, and I hope that we can make this a standard practice, because we already know from what I showed you earlier that mental health in oncology patients is prevalent. And mental health in oncology patients impact their beliefs and their perceptions and their behaviors. So a multidisciplinary approach, we want to engage oncologists, psychiatrists, psychologists, and mental health support. So when I was in R&D, we weren't thinking about this, right? We didn't think about these individuals as partners, but I think we should start thinking about mental health advocates, mental health professionals as part of that team, as part of that support team, when we are building out protocols and looking for different, maybe even advocacy groups or different resources on how we can support not only patients, but even sites, right, on how to manage these individuals. Then we have mind-body interventions. There was just some research done on evidence-based approaches that are non-pharmacological in treating these patients. So they're out there. It's just how do we incorporate them into what we're doing in the clinic. Technology-driven monitoring, so using digital tools for real-life mental health tracking, incorporating those things. So many people say it's a heavy lift, but we have, the last gentleman that was up here was talking about AI. There are so many AI devices and ways we can really monitor and track patients in real time. And then we have patient-centered endpoints, maybe including a quality of life endpoint in our clinical trials. So making that priority, because if it's an endpoint, we have to track it, right? We have to look at that data, we have to evaluate that data, and really make changes. And I would be remiss if I didn't talk about diversity, equity, and inclusion in trials. Now, this is a really hot topic now, especially now in our political climate. However, I know many sponsors are still dedicated to increasing diversity, equity, and inclusion in clinical trials. But some of the barriers to this are lack of awareness of clinical trials. A lot of marginalized individuals don't know about trials, limited health literacy, mistrust of healthcare systems, and perceptions and fear of clinical trials. And we already know that minority oncology patients often experience high levels of emotional and mental distress due to various factors, including discrimination. So with this being said, we already know what they're coming in with that baseline, then you put cancer on top of that. So if we are looking to increase our diversity numbers in clinical trials, what would happen if we had a component addressing the mental and emotional impact of cancer? We may be able to recruit and retain more of these individuals, but something just to think about. And this is standard information that's already out there. So future innovations in mental health and oncology trials. So as I mentioned, AI and machine learning, predicting mental health risk and tailoring interventions. Wearable technologies, tracking stress and mood biomarkers to guide psychological support. Personalized psycho-oncology programs, so a customized mental health care based patient profile. So it's really based on that specific patient. And then policy advocacy, ensuring regulatory bodies mandates mental health assessments in clinical trials because they do have an impact. And then this here is my last slide, and it really is a call to action, and it's shaping the future of oncology clinical trials. And this is really for sponsors, researchers. We have to prioritize mental health. And we can do that by, doing assessments, looking at the PROs, having diverse resources for these patients, and partnering with mental health professionals, and building them into our protocols as essential partners who will help address the needs of these patients. And one thing about oncology clinical trials, what we have an advantage is because many clinical organizations don't have the time, they don't have the staff, right, to really address this. So if we are bringing a clinical trial to a site as a sponsor, you're able to bring this to the site, which is an oncology intervention to really fill that gap that exists and has existed for a very, very, very long time. So with that, I want to open it up for questions and discussions, because I would love to get your thoughts on what I presented here, because that's going to help just inform, how we kind of move forward. So I will take any questions.
Well, thank you, Wendy. So any questions? Because
there was a question back there.
Plenty of time.
I don't know if you hear what I spoke yesterday about being an advocate and survivor. Now, where the place that I am working with, we only have 3 therapists on staff, and we do, sorry, online and in-person support groups, and we do artwork, writing, and all kinds of things. I happen to be one of the people that is very affected by cancer. My mental health is horrible. And what you're saying is true, and like the hospital I go to, there's only one mental health professional there. So this makes a big part because a lot of us are so afraid of cancer, and we have nobody to talk to, and it just sits on you, and the stress is horrible. So I found this place, and it's really awesome, and I hope other places can open up like this, and anybody can really join, because there are a lot of online groups too, through Zoom. So it just makes a difference when you have people that you can tell things to, because some people don't understand a lot of things.
Yes,
Thank you for what you're doing.
thank you for that. And what's your name? Dolores, that's a great point. And one thing that I'm finding just in the clinical setting is there are a lot of programs out there like that. A lot of advocacy groups are doing great work. However, there's a gap that exists between those resources and the clinical practitioners or healthcare professionals. So we have all these advocacy groups, all these programs that no one knows about. The people who are seeing the patients in the clinic have no idea. So yeah. So it's really trying to bridge that gap, and I think that's one thing we do very well because we don't belong to any organization, so we don't have any red tape, but we connect our patients to resources just like that. So I would love to learn more about that program you're referring to. Thank you.
Very good talk, and I'd like to know: do you have very good positive results from your clinical trial? Yesterday, I gave the talk. I know. Let my mice, after my treatment, listen to music, let the mice live longer and more activities. I know human more complicated, but if you have the mentally, record how your results, how improved the clinical trials.
Say that again. I didn't get the question.
And do you have any positive results? You give take care the mentally and not take care the mentally. After the clinical trial, get it better, live longer, or tumor get shrink better?
Yeah,
Or,
I don't have any independent research on it. However, my real-world evidence of dealing with cancer patients, that's my research, that real-world. But I don't have any independent research where I looked at patients who receive therapy and who do not receive therapy. Because even now in the clinic, we're seeing patients who can't even make a decision if they want to start a new treatment because of their mental health, right? Despite their disease progressing. But thank you for the question. Anyone else? Oh, there's one gentleman behind you with the microphone.
Regarding the exclusion category from the sponsor side, playing the devil's advocate, as a sponsor, I want to make sure a product that I've worked on for 20-some years has minimum interference from other factors that may not be relevant to my drug. So it's justified, isn't it? Because if somebody dies on that clinical trial, then other people who can benefit from it are going to be put on hold.
Yeah, no, I understand that because you want cleaner data. I get that working in pharma. I understand that. However, I would just like people to be open to it. To say, well, if we have someone who meets the criteria, because many times we can't meet our recruitment numbers, right? So what if we have patients who may have a mental health diagnosis that qualifies, that meets everything else, but we're saying no because they have this. Whereas a sponsor, maybe we can provide, how we provide brochures on the actual tumor, on the trial, maybe providing a mental health resource to that patient pre-enrollment can help that patient be ready to be a participant in that trial. So I get what you're saying because because we develop, right, inclusion. I develop protocols and I understand what goes into it and why and how, but I want sponsors to be open to it. Was there another question?
Yeah, I have.
Oh,
Yeah, well, I'm working now in 2 different kind of areas, yeah, and we included, we include all the mental health. What I'm trying to say in this word, emotional support. So in working with a big group of people we are HIV, so living with HIV, and in the oncology, okay. So we give support. It's amazing how much do they change, but we give emotional support, which is quite a little bit different, because the thing that the patient's concern is, I am taking pills. If I go to see a psychiatrist, I'm going to continue taking more pills. I don't want pills. Yeah, so this is the first thing that you face when you say, oh, you need to be, you are in depression or you're about to be depressed. So the first fear that the patient have in both, yeah, is, oh, come on, I give up already, So that was, we changed the word and said emotional, so you feel welcome.
Yes.
This is the first one thing. Secondly, we create interventional models, short-term interventional models, where we train the patient who have been already quite a while, and they drive, they stay in the group, they support the group. So rather than be a doctor or a nurse, they are the patients. So
Yes.
that made a huge change too, because, who understands you better?
Right, right.
Yes, it's a suggestion because we have done already, and that improves a lot the response. Or at least, talking about with a patient here, at least you feel welcome and you feel better understood.
Yes.
And that made huge differences. Opposite to that, we face a lot of patients who didn't even want to receive any emotional support. And so we ask ourselves why. And this is because talking about Latin America, but I think that you have here exactly the same problem. They are not believing. They stop believing in therapy, they are not depressed. Yeah, it's not the depression, because we need to be so careful when we talk about depression, or is it really depression, it's just only a problem of that they feeling lonely and all this kind of thing. But this is a point that we need to create maybe another way to approach to them.
Yeah.
More like a family.
Yes, yes. Yeah,
Because you need to do this is a clinical trial. It's like we fire them with so much knowledge and blah, blah, blah. So at the end of the day, it's kind of, rather than, hello, can we go, have a chat and drink a coffee and, more in that way work for us. So I can say for long term, because we just starting analyzing the variables and these things, because it's all in platforms, yeah. But I think that this is excellent, the thing that you are doing, and I'm planning to do, and I hope that everybody just listen to you and that you can integrate this on the daily basis, like a blood test.
Yes, absolutely, absolutely. So just 2 things. I know we're running out of time, but the
you have still 4
Oh, okay.
minutes.
Your point to patient-run groups, emotional support groups are definitely essential. A lot of advocacy groups have them, but we're not utilizing them in that way. Right? So when, sponsors, partner with advocacy groups saying that, like we would want, I know breast cancer, they have a lot of groups, they call it navigation. They call it like patient navigation, which is essential. But if we make a point to say we want to partner with this advocacy group, whether it's HIV or cancer, for emotional support, I think that that's very important. But we're not doing it consistently, I would say. We're not doing it consistently. So I do like that point. To your other point about the barriers of patient accepting emotional support, we have to provide culturally sensitive approach to individuals. So whether it's, someone from Latin, whether they're African American, whether it's the LGBTQ, but we have to be sensitive to those individuals. And many times, I always talk about this, and I'm glad you let me say this now, because when I'm talking to my clients in the clinic, I always say, I call it identity dissonance. right? So we all know ourselves one way, right, before cancer. Then after cancer, you're really trying to define who are you? What do you want? And that comes with emotions as well. How am I emotionally going to handle this? Because we have patients who resist. They don't want to see us at all. And then after months, they come and say, I do need this.
Yeah.
I do need this. And I think it's the mental stigma.
Yeah.
There's still stigma around mental health, even if people are battling cancer. So I think it's how we frame it, and that's why it's really important that in clinics that, we are conscious of who we're serving, how we're serving, and their needs. So it really definitely starts from that clinical standpoint.
Yeah. Well, thank you very much.
Thank you.